Hello, everybody. Welcome to our musings on protecting your kidney, heart, and metabolism from complications. I'm Jim Carroll. I'm the CEO of the diaTribe Foundation, and I'm thrilled to be here with all of you, our esteemed panelists, our dedicated sponsors, and you, our engaged audience, who share our passion for improving the lives of people with diabetes. Did you know that March is Kidney Month? So it's a perfect time to raise awareness about kidney disease as well as the many other factors that influence the health of people with diabetes, because managing diabetes isn't just about glucose control. It's about comprehensive, proactive care, especially kidney and heart health. Before we dive into today's discussion, I'd like to take a moment to recognize and thank the incredible sponsors who make musings possible and free to everyone in our global audience. Starting with our gold sponsors, Abbott and Xeris. I want to thank them for their leadership and their commitment to innovation. Abbott continues to advance CGM technology, making glucose monitoring seamless and effective, while Xeris ensures that education and access to ready-to-use glucagon remains a priority in addressing hypoglycemia. Our silver sponsors include the BI Alliance, who's here with us on the panel today, Eli-Lilly and Company and Vertex. The BI-Lilly Alliance and Eli-Lilly are shaping the future of diabetes therapies, and Vertex is driving innovation in cell-based treatments that could transform the landscape of type 1 diabetes care. It's very exciting. And our thanks to our bronze sponsor, Dexcom, for their continued dedication to improving diabetes management through technology. The support of all these sponsors fuels the conversations we have here, conversations that spark new ideas, challenge assumptions, and hopefully inspire us to act. Our moderator today, Dr. Diana Isaacs, is a nationally recognized expert in diabetes management and technology. She's an endocrine clinical pharmacy specialist and the CGM program coordinator at the Cleveland Clinic. She's a passionate advocate for expanding access to diabetes technology. And Diana, along with Natalie Bellini, host a monthly podcast. It's called Diabetes Dialogue, Technology, Therapeutics, and Real-World Perspectives. We'll put the link to her podcast in the chat. We're fortunate to have such incredible expertise guiding us today. And so with that, I'll turn it over to Diana to get us started. Diana?
Great. Well, thank you so much for that very kind introduction. I am so excited to be here today to talk about this really important topic and to have an amazing panel to do so. So without further ado, I'd like to go ahead and announce our first panelist, which is Dr. Robert Gabbay. He brings a wealth of experience in diabetes research, clinical care, and health policy. An associate professor at Harvard Medical School and the Joslin Diabetes Center, Dr. Gabbay previously served as Chief Scientific and Medical Officer of the American Diabetes Association, where he led groundbreaking initiatives to improve diabetes treatment and outcomes. His expertise spans healthcare transformation, patient-centered care, and the integration of new technologies into clinical practice. Please welcome Dr. Robert Gabbay. It's great to have you here. All right, next we have Dr. Jennifer Green, a professor of medicine at the Duke Clinical Research Institute at Duke University School of Medicine. Dr. Green is a leading expert in the intersection of diabetes and cardiovascular disease, with extensive research on how emerging therapies impact long-term outcomes for people with diabetes. Her work has influenced treatment guidelines and helped shape the way we think about cardiometabolic health. Please welcome Dr. Jennifer Green.
Hi, I'm really very excited to be here.
Great. We are so excited to have you both. And then our final panelist, Dr. Thishi Surendranathan, is a key leader in the field of cardiorenal metabolic medicine. As director in cardiorenal metabolic medical affairs at Boehringer Inghelheim, he plays a critical role in advancing research and medical strategy for innovative therapies that address the interconnected nature of diabetes, kidney disease, and heart disease. His insights bridge the gap between cutting-edge science and real-world clinical application. Please welcome Dr. Thishi Surendranathan.
Hi, everybody.
Great. Well, it's so wonderful. I'm so excited to have you all here today. So, Heart and kidney problems are common and serious complications for people with diabetes. But the good news is that we now have better tools and treatments to help prevent and manage these conditions. So today we'll talk about the tests that can catch problems early, the latest treatments that can protect your heart and kidneys, and practical steps that you can take to really improve your health. And to get us started, I'm going to ask the first question to Dr. Surendranathan. Why is regular screening for heart and kidney health so critical for people with diabetes?
That's a great question. So I'll start with chronic kidney disease. So chronic kidney disease is a complication, an end organ complication of diabetes. Diabetes and hypertension are two of the most common causes of chronic kidney disease. As it progresses, you get worsening kidney function. You can get leakage of protein in your urine, and if it progresses far enough, you can get end-stage kidney disease and go on to dialysis. But what I would say is, for most people, that is actually not probably the biggest concern. I would say the biggest concern is when you have chronic kidney disease, it's actually an independent risk factor for cardiovascular disease. And even before you get to that end stage, you are much more likely to have a cardiovascular event. And and so this is really big implications for example, mortality or morbidity. And it's really important to screen for chronic kidney disease, especially because it's in many patients silent. So really, really important thing to be looking out for.
Yeah, great points. And along with that, I mean, what are the risks if you miss the early warning signs?
So, it's tricky because there are no, in terms of symptoms, there's often no early warning signs. So it can be, as I said, completely silent. You may have a non-specific malaise or fatigue, but most likely it will be something that's picked up on a blood test. And it happens. You can get a gradual decline in your kidney function over years as you get older. And actually, that's one reason why it frequently gets missed, because often doctors don't necessarily have a trigger in their head or an alert which makes them think, oh, this is something I need to do something about. But if you put kidney disease in amongst some other risk factors for cardiovascular disease, we know that, for example, almost half Americans adults, have 3 or more cardiovascular risk factors. Then what you've got is like a multiplier for your risk. And so your primary care practitioner needs to be really on top of all of these risk factors and how they come together to heighten your cardiovascular risk. So really important that these patients with diabetes, with high blood pressure, get screened with the right tests, and so they can be really assessed for their risk.
So speaking of that, what are the most common tests for heart and kidney problems, and what kind of information do these tests give doctors and people with diabetes?
So kidney disease is actually quite simple. There's a blood test and there's a urine test. So for the blood test, there's something called EGFR, estimated glomerular filtration rate. It's a test which tells you about the rate at which your kidney is filtering the blood of waste products, and it's actually on pretty much every normal sort of standard biochemistry panel. So if you've had a blood test, doctor, almost certainly you've had this EGFR, it's yes, that's the EGFR. Sorry, that's what I was going to say. So the calculation for that EGFR is based on your serum creatinine, your age, and your gender. Usually, there are some more accurate ways of doing it, but that's what most labs have, and that's how they calculate EGFR. If you the other test though is something called UACR, it's a urine albumin creatinine ratio, and it's actually a test of kind of the leakiness of your kidney in terms of leakiness to protein. So the reason that this test is important is on top of your GFR, it tells you about kidney damage. and in itself is a marker, a key marker of your cardiovascular risk. So the two tests together tell you firstly whether you have kidney disease, and even when you do have kidney disease, it tells you a bit more about the level of risk you've got for cardiovascular disease. So really, really important tests.
Great. Thank you so much for explaining that. These tests are really important, definitely for staying on top of your health and everything. And these tests, we know, can help people catch potential problems earlier. Dr. Green, I want to go ahead and turn it over to you to explain if there's any additional tests, maybe some less common tests that patients might want to ask about. And also, just with all these testing, how often should people be getting them?
Yeah, absolutely. So you've already heard a little bit about the measurement of creatinine to calculate the eGFR and measurement of the urine albumin to creatinine ratio. It's important to note that they should be checked at least once a year in everybody with type 2 diabetes, starting at the time that they're diagnosed with diabetes. And then if someone has had type 1 diabetes for at least 5 years, they should also have the lab work done at least once a year. Now, if the results are normal, then once a year may be enough. However, if the levels are abnormal, if the eGFR is low or the urine albumin to creatinine ratio is elevated, recommendations are to monitor the levels more frequently. But those are really the kind of gold standard for assessing and monitoring for kidney disease in people with type 2 diabetes. Then most of the time in people with diabetes, kidney disease is related to diabetes and perhaps hypertension, high blood pressure as well. If, however, the general medical doctor or the kidney specialist thinks that there might be something else going on or something additional going on contributing to the kidney disease, then they might order, for example, a kidney ultrasound or even do a kidney biopsy. But most of the time, that's not required. Okay, so I think we've covered the kidney part of this. So moving on to assessment for example, heart disease. In general, in the past, it really wasn't recommended that we screen people for heart disease if they were feeling fine, if they didn't have any signs or symptoms suggestive of heart disease. But there have been some very recent changes. And in particular, let's focus on heart failure. The American Diabetes Association has just recommended this year that we consider measuring what's abbreviated an N-terminal proBNP to assess a person's heart failure risk, even if they don't have symptoms of heart failure. And that is because the level can be high if a person has had some structural or physical changes to the heart muscle itself, even before they develop symptoms or signs like being short of breath or developing swelling in their legs. And if that N-terminal proBNP level is found to be elevated, then the next step would be to perform an echocardiogram, basically an ultrasound of the heart. And medical therapy could be modified if caught early to reduce the risk that a person would actually develop symptoms of heart failure. The other thing that I would mention is that in my clinic, I not infrequently order a coronary calcium score if I think someone may be at higher risk for coronary artery disease, so atherosclerosis involving the arteries that supply the heart muscle, then is obvious to me from their blood tests, for example. And this is an easy, non-invasive test. Basically, it's a CT scan that measures the amount of calcium buildup in the coronary arteries. And I will order this if, for example, I need to figure out whether or not I need to treat someone's cholesterol more aggressively than I might otherwise if I didn't know that they had calcium in their coronary arteries. Also, if the calcium score is high on the test, then I might refer the patient to a cardiologist for further evaluation, maybe with a stress test or with other more advanced imaging of the flow in the arteries around the heart. But the coronary calcium test is really easy and fortunately a fairly inexpensive step to assess for what we call atherosclerotic heart disease.
Thank you. That was a fantastic overview of all those different types of tests. I'm curious. So when people are, sometimes labs are ordered and people don't really know what was ordered, and they start to look through their results and they might see EGFR and maybe it's slightly low, or they see albuminuria. How do you kind of talk about this in a way or explain this to patients in simple terms so they can understand?
Oh, yeah. So it's really important to understand why the tests are being ordered and what the results mean. That's kind of the basics. So as was mentioned before, creatinine is a waste product that comes from your body's muscles. It's cleared by the kidneys. And again, the level in the blood is used to calculate the EGFR. EGFR stands for the estimated glomerular filtration rate, which is a blood test that basically measures how well your kidneys are filtering waste from your blood. And the EGFR is calculated using the creatinine value, but also your age, sex, body size, for example, and it gives you a more nuanced or individualized estimate of kidney function than just measuring creatinine, which is not a particularly good test at understanding the overall kidney function. Now, in some situations, a different blood test might be ordered to calculate the EGFR, and that would be a cystatin C, which is a protein that's filtered by the kidneys. And sometimes that's considered a better test in people who have either very low muscle mass or very high muscle mass, like, for example, a bodybuilder where the creatinine-based EGFR calculation might not be accurate. Again, you've heard a little bit about the urine albumin to creatinine ratio. If the filters in the kidney are damaged, if the endothelial lining in the kidney is damaged, then albumin can leak through the blood into the urine. Ordinarily, there should be little to no albumin in the urine. So when that is present, particularly at elevated levels, then that is a sign of kidney damage. And then I did mention the N-terminal proBNP, which is this test to determine whether or not someone already has or is at high risk for developing heart failure. And it's a really good indicator of that condition because it's a hormone that's released by the heart in response to stress, such as fluid overload. So we use that to look for heart failure, and then it can be used over time in people with heart failure to see how well their medical management is working.
Awesome. I think it's great. There's so many tests that people can really get, like, they can really know how their kidney function, their heart function, all of that is. It's not like a guessing game. So that is fantastic. So our hearts, our kidneys, and our metabolism are really all connected, which is why we talk about them together. And we use the term cardiorenal metabolic system. So when one part is out of balance, it can affect the others. And understanding this connection can really help you and your healthcare team manage your health more effectively. So next question is for Dr. Gabbay. Why is it important for people with diabetes to think about their heart, their kidneys, and their metabolism as one connected system?
Dr. Isaac, they're all connected, so much so. So somebody that has heart dysfunction often will cause kidney dysfunction. The kidneys secrete hormones that control blood pressure that can affect the heart. Glucose levels can affect both the heart and the kidney. So they're really all interconnected. And if you've got one, you're at risk for the other too. So it's important to think of them together. The other thing I want to just maybe simplify things a little bit because we heard a lot of really eloquent so bottom line, it's pretty so people will not generally know they have kidney disease. That's why screening is so important, and people are often not screened. You won't know that you have it until you've got really severe disease, in which case there's less that can be done. So a simple blood test and a simple urine test, that's all it takes. And it can be done really in any lab. Your healthcare professional may already be doing it and you may not know, but it's something you should ask that, am I being screened every year for kidney disease?
Yeah, great points. I've learned people really, it helps to advocate for your own health. And I've also seen where people, they're getting the test done, but no one's explaining to them what the results
Yes.
mean. And I think that's also really important too. that people understand and someone takes the time to go over what those results are. So another question for you, Dr. Gabbay, we know that certain medications like statins and drugs that may lower blood pressure can also help to protect the heart and the kidneys. So what treatment combinations have been shown to work well together, and what should patients know about how these therapies work?
That's a great question. So, I think we're really in exciting times where there are so many things that can be done to prevent people from developing kidney failure and ultimately needing dialysis. We largely have the tools that if we caught people early enough, people shouldn't have to develop kidney disease from diabetes to the point where they need dialysis. So I was actually just sort of thinking through this, and I could give you like the top 10 things you can do to prevent kidney disease. So starts with smoking. And if you do smoke, quitting smoking, because smoking is bad for the heart and bad for the kidneys. And there are medications to help, and speak to your healthcare professional around that. Exercise is really helpful, both for, again, kidney, heart, and metabolism. And again, be if you're starting an exercise program, speak to your healthcare professional. Start slow, gradually, all of that kind of good stuff. Um, Sodium plays an important role in terms of diet, and so that's the number 3 on the top 10 list. A lower sodium diet. 2.3 grams a day, 2,300 milligrams. Uh, how do you know if you're on get how much sodium you're getting? Look at the label, and I can tell you that if you eat anything that comes in a can, it generally has a lot of sodium in it. So that's a good one to try to avoid canned foods. So that's 3 out of our top 10. Weight management. We know that living with obesity increases the risk both of kidney disease and heart disease, and so managing that. Um, and then we start getting into the more specific things. So blood pressure is super important, and maintaining a healthy blood pressure. And the goal for blood pressure a healthy blood pressure for people at risk for kidney and heart disease is a lot lower than we used to think. Uh, you want that blood pressure less than 130 over 80. 130 over 80. So that's a lower than we used to thought healthy, and it's because we know that if you can keep that blood pressure down, you can again prevent these issues from becoming a problem. Uh, Another important area is cholesterol. Increases the risk both of heart disease and kidney disease, and statin therapy in particular is helpful in both ways. So I think we're up to like 6 or 7 here. Uh, the albumin creatinine, that urine test that we talked about, there are medicines that can lower that and be protective. And so let's switch to the medicines that can be helpful. One class of drugs that we'll talk about more in a moment, I think amongst all of us, are these medicines called SGLT2 inhibitors. They've really revolutionized the treatment for both kidney disease in people with diabetes and heart failure. Super effective drugs, and we'll talk more about them. Uh, uh, ACE and ARB inhibitors, they're blood pressure medications. They're usually the first line medicines for somebody that has high blood pressure, also very helpful. Um, and then the GLP-1 receptor agonists that have become very popular in terms of their weight loss effect. Uh, some of them can also help in terms of protecting the kidneys, and we also know that they protect the heart. Um, and then last is a medication called finerenone that also helps in terms of kidney disease. So there are literally 10 different things that you can be doing to lower your risk of kidney and heart disease. So there's a lot that can be done. And again, the key is screen early so that you can do something before it gets too late.
Thank you so much for that overview. I love how I asked about medications and you really incorporated all the lifestyle things that people can do as well, because they really go hand in hand. So I really appreciate it. And before I ask my next question, I just want to encourage the audience. We will have time towards the end for you to ask your questions to the panel. So if you have questions, please feel free to put them into the chat. And also, I just want to encourage my panelists. I know I've been directing questions to each of you, but if you have something to add, please feel free to add. I want you to feel free to do that as well. All right. So with that being said, I am going to turn the next question back to you, Dr. Surendranathan, and kind of get into a little bit more depth about kidney disease and medications that can really be used to protect the kidneys. And I'm so happy that I'm seeing patients now that have had very long-standing type 1 or type 2 diabetes, and their kidney function, everything's going great, thanks to kind of these lifestyle modifications people can do and the benefits of the medications we have. So specifically, some of our newer medications like GLP-1 receptor agonists, SGLT2 inhibitors, and then the non-steroidal mineralocorticoid receptor antagonist finerenone that we just heard Dr. Gabbay mention. How are they helping people with CKD?
So it's interesting. We should just take a little bit of a history lesson, because you're right, this is a really exciting space to be working in. And it's actually getting even more exciting because there's more work being done, more research, and a few different companies are dedicated to developing medicines in this space. What's interesting about the so-called newer therapies, SGLT2s and GLP-1s, is that actually they've been around for a little while. And originally they were developed to treat specifically diabetes and to control blood sugar levels. I think towards the late 2000s, the FDA kind of mandated that if you have a new diabetes drug, they really need to be tested from a safety point of view for their cardiovascular risks. And so these trials are done as a matter of course. But a surprising thing came about, which was that in the SGLT2s, there was actually benefit versus placebo on the cardiovascular outcomes, so significant that that the company decided to embark on these big new trials to investigate the effectiveness in things like kidney disease, heart failure, and even more interesting than that actually was that these drugs were effective in patients who, not just in patients who had diabetes, but patients without diabetes in chronic kidney disease and heart failure. So that tells you something, that this caught people by surprise because it wasn't actually understood exactly how these drugs work, and now they're working on other things which are also beneficial. So I think actually that's precipitated a whole new line of thinking about how all these different systems are interconnected, and I still don't think we really completely understand. But there are clues with these new medications. So the SGLT2s, which we just mentioned, these act on the kidney. They promote or they block the reabsorption of glucose and sodium. And so there is something in that action which lessens the what's the word? Some of the pressure, the kind of injury on kidneys over time that you get with diabetes, and helps to slow the progression of kidney disease in these patients, and they also have beneficial impact on the heart. So whichever type of heart failure that you've got, we heard earlier about the echocardiogram test that you get for heart failure. That test divides you into one of two groups: heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. These, regardless of the type, these SGLT2 inhibitors have a beneficial effect on heart failure outcomes. And then I think when we had those drugs approved, I think that's also with this data coming out that prompted other companies to have a look at this space. So actually, GLP-1s, which are obviously known for controlling blood sugar, also in having this weight loss effect, they are also being investigated in these complications of diabetes, such as kidney disease and heart failure. So you've had one of them has been approved for example, in diabetic kidney disease recently, and there's more research going on. So watch for that space. And the other group of drugs that Dr. Gabbay just mentioned was the non-steroidal MRAs. They one has been approved in diabetic in kidney disease to slow the progression and improve cardiovascular outcomes. So as I was saying, this is a really exciting time. The guidelines are struggling to keep up. I know the ADA do a fantastic job updating these every year. So actually you do have up-to-date guidelines, but watch how they change even from year to year as new data comes out. And it's really important to keep an eye on and watch the research that comes through in the next years, because you're going to see some interesting developments.
Yeah, I mean, it's been really incredible to see where we've come and how far we've gone. I still remember when SGLT2 inhibitors first came out. The first one was canagliflozin, and we were all like, we were nervous in my circles that, oh my goodness, they work on the kidneys. Are they going to cause damage? Is this going to be a problem? And now all these trials have shown that not only is it not a problem, but it's beneficial. And we should have people with and without diabetes on this class of medication. So it's really incredible. So with all these different options that we have now, what should patients and healthcare providers consider when deciding which medications might be right for them?
That's an excellent question. I actually think because there are so many different options, it actually can be a little bit kind of confusing. So as I mentioned earlier, the ADA standards of care, I think actually does a really good job of telling you what you might be thinking of. And there are points within that where you can, it's kind of like an either or decision about which drug you use. In general, you can say if you have a diabetic patient and they've got heart failure or chronic kidney disease, certainly consider the SGLT2. But then if you've also got glycemic control considerations, then you probably want to be thinking about a GLP-1 on top. But then you've got patients with glycemic control issues, and they've got established cardiovascular disease. For those patients, it could be a GLP-1, could be a SGLT2, and then maybe an additional, and vice versa, adding the other if you want to control blood glucose. And then if you've got obesity and that's a predominant issue, then you want to be thinking maybe GLP-1s are more the thing to think about. But it's not a straightforward choice. Some of it is to do really specifically to the patient and their preference as well. And also, what's nice is, from what we can tell, no studies really answer this question properly, but in terms of the mechanism for effect on kidney disease or heart failure, it looks like there might be a complementary effect of some of these medications. So adding them seems to have some benefit. So that's kind of nice, but as I said, we don't actually really understand how all these things work. So if we can elucidate that, then maybe we'll have an even better idea how to use these drugs properly.
Great. Well, thanks. Yeah, I mean, it's definitely shared decision making and individualized based on different patient factors, but at least we have the ADA treatment algorithm, which I think does a great job of, at least if someone has kidney disease or they have cardiovascular disease or heart failure, really guiding us at least into the therapies that can help them. So I'm going to switch on to a slightly different area, just the management of all this care. So having diabetes, heart health, and kidney health may require care from different specialists, right? And so communication amongst that team can make a really big difference in a person's health. So Dr. Green, Question for you: when should a person consider seeing a specialist, like maybe a cardiologist for their heart or a nephrologist for their kidneys? And what can patients do to make sure their different doctors are working together and sharing this information?
Oh, that's a good question. And honestly, sometimes healthcare providers struggle with that question as well. So don't forget that you can always ask, and you can, you won't hurt anyone's feelings if you ask. For example, at what point would this be serious enough that I would need to see a specialist about it? That's not going to upset anybody or hurt anyone's feelings. Advocate for yourself. There are some rules of thumb, though, and I kind of think the guidance with respect to kidney disease is pretty straightforward. So it's recommended that you see a kidney specialist if your eGFR is less than 30, or if your urine albumin to creatinine ratio, the amount of albumin in your urine is severely elevated. That would be greater than 300 milligrams per gram. There are other reasons too, of course. If those levels are significantly worsening over time, that would be a reason to see a nephrologist as well, a kidney specialist. And also, if it's not entirely clear that kidney disease is related to diabetes or high blood pressure. With respect to seeing a heart specialist, if a person has signs or symptoms worrisome for either heart failure or coronary heart disease, so that would be shortness of breath, chest pain, limitation to their ability to be active that isn't explained by another diagnosis, that would be a good reason. We're doing a lot of these screening tests now, the coronary calcium measurement that I'd mentioned before. If I see that someone has a moderate or severe amount of calcium on their coronary CT, I would probably send them to a cardiologist for further evaluation with additional testing. And this screening for heart failure with measurement of the N-terminal proBNP, this is a new recommendation. And I think we're all trying to wrap our head around whether or not somebody who has a high hormone level but doesn't have symptoms of heart failure automatically needs to see a cardiologist. I think that the answer is probably not, but we're going to need to figure that out. Now, communication, of course, is key. We don't want people to be working at cross purposes. We want everybody to know what diagnoses or problems are present and need to be addressed. Obviously, if you see doctors within the same health system, that's a little bit easier. But encourage your doctors, if they're in different health systems, to make sure that they're looking at notes from the other doctors. Sometimes picking up the phone is really the best recourse. And as far as communication goes, communication between specialists is really key, for example, to changing healthcare on a larger scale, and making sure that doctors, so example, kidney specialists, diabetes management specialists, cardiologists, heart specialists, are communicating with each other and have a process in place to do so and have their questions answered is really key to making sure that not just one person's healthcare is improved, but that the care of essentially everybody with those conditions can be improved. So you can certainly ask, and I think people are used to doing this. Have you seen the notes from my cardiologist? I was just there last week. Please, again, advocate for yourself. At minimum, it might spare you from some repeat testing that just doesn't need to be done.
Thanks. Yeah, I know I appreciate when patients just proactively let me know, hey, I had this visit last week, because sometimes it's just, there's so much in the chart and it can be missed. So Dr. Gray, not to totally put you on the spot, but I'm wondering if you could share an example of how better communication amongst doctors helped improve a patient's health.
Well, I'm going to give you a kind of a bigger example, not just having to do with one patient, but here at Duke, we ran a study called Coordinate Diabetes. And to kind of make it simple, this was a trial of cardiology clinics across the United States who enrolled patients with diabetes and established atherosclerotic cardiovascular disease. And those patients all had indications for treatment with some basic medications. And the patients there, however, were not being treated to what is considered standard of care. And as part of this study intervention, it included a requirement for the doctors at those clinics to communicate with a local diabetes care specialist about, for example, changes in care that included the addition of new diabetes medications that help protect the heart and kidneys. And in the study, we found that that communication as really a key part of what was a very simple intervention program resulted in significantly better medical care for the patients who were enrolled in the study at those clinics. And care was improved for both men and women and in people across racial and ethnic groups. So that was a key message that we sent. And the cardiology clinics that had clear channels of communication with the diabetes specialist really did very, very well at kind of overcoming what are common obstacles to getting everybody on the medications that are indicated to keep their heart and kidneys healthy.
Awesome. That sounds like an amazing program. Thank you for sharing. All right. Well, next, I want to talk about hope. So it's understandable to feel worried about potential complications like dialysis. But the reality is that today is so much more hopeful. Dialysis is hardly inevitable. So by staying informed, really getting regular tests and working with your healthcare team, you can take steps to improve your health and live a full, vibrant life. So Dr. Gabbay, how do you help patients move past fear and just feel more confident in managing their diabetes and related risks?
It's a great question. I mean, to some degree, we all can get nervous about what could happen, and I think for many folks, the best way to deal with that is to know that you have control, that there's something you can do about it. You can get screened early, and then we just went through 10 different things that you could do to help your kidney and heart health. So there's a lot that can be done. The key again is catching things early, because it's so sad when will have a patient refer to me that's already very far advanced in their disease, and there's still something that can be done, but you always wish we could have caught them sooner. So I think there's so much that can be done, and the new medicines that we were talking about, uh, that's all happened just like in the last decade. Before that, this list of things you could do was much shorter, and we didn't know a lot of things that could be done. Now there are a lot of things that can be done.
Yeah, I mean, I think that is very empowering that there is so much people can do now to really advocate for their health and prevent potential complications. But we know that there still are some challenges. So I'm curious, Dr. Gabbay, if you can comment on what challenges make it hard for patients to maybe get the latest treatments, and what can healthcare professionals and patients do to address these barriers?
Well, I think there are a number of things. One is access to care, uh, and also access to medication. Some of them may be expensive depending on coverage and all of those issues. Um, there are programs available for people that are unable to afford medications. Usually, your healthcare professional can point the way for that. So I think being able to afford and have access to the treatments. And that's where, a number of organizations like the American Diabetes Association are advocating uh, to ensure that people do have access to treatment. So I think that's one barrier. Um, Another is life. Like life is hectic. People are busy, right? And to think about all the things that they need to do, it can get in the way. You know, Going to see your healthcare professional regularly is a great reminder because they'll sit down and say, okay, let's think about what we can do together, and don't try to do all 10 things that I described. Pick one or two that you're going to work on because that's a lot more likely. It's impossible. I could never change 10 things in my life at once. I'm lucky if I could do one or two. But one or two with the right goal and with some coaching is doable.
Great advice. I'm curious to hear from the other panelists, any challenges that you've identified in accessing these latest treatments, or better yet, solutions to address some of these challenges.
I'm happy to start. One thing that I will say is that some of these newer medicines that are provide protection to the heart and the kidneys may be available in generic formulations soon. So there could be an opportunity to use these medications at lower prices. We'll see how that plays out. I do think too that. Well, if we're talking about access, many people's insurance coverage will cover one of the beneficial drugs in each class. Now, it can be difficult for your doctor or pharmacist to figure out which one of those it is. But I would encourage healthcare providers and you to ask to keep trying until you figure out which one it is. I wish it were more straightforward, but the fact is that most people with diabetes who are considered at high risk for these complications can access these drugs. It's not an easy road, and it requires some extra work, but keep trying. It is worth it.
Great points. Yeah. And Dr. Surendranathan, anything to add?
Just one thing. I've realized that we've had a conversation and we haven't really mentioned a drug that is available in generics, this class of ACEs and ARBs. Oh, we have actually. Dr. Gabbay mentioned it earlier. But when I was laying out the treatment guidelines, this is actually really a mainstay of treatment, and almost everybody who's at risk should be on these drugs first and foremost before you start thinking about some of the newer medications. Just from an access point of view, in case anyone has this question, our company, Boehringer Inghelheim, does have an access program for certain eligible people that helps get the drug to patients for free, specifically in patients who have below a certain income level, and also some senior citizens as well. So it's worth looking up on our website. But also, I imagine that the pharmacist who would be looking after you would have a really good idea about the best way you can access the drugs outside of our company as well.
Great, thanks. Yeah, I mean, when it comes to the cost and the access, I think this is just such a quickly evolving field. I mean, even just in the last week or two, we've heard about some new programs for some of the GLP-1 agonist drugs, and that's going to make a lower price option, especially for people that maybe don't have insurance coverage. So I'd encourage all of you listening that even if in the past you heard your insurance company wasn't covering it, or you couldn't get it, or it was too expensive, keep asking, keep trying, because this is such a quickly moving area, especially when it comes to now using these drugs like in obesity too. We're seeing that the coverage is expanding, and that is just making access a whole lot better. And then just to address another kind of what Dr. Gabbay was saying, I mean, I find following up is often patients that just come to see me and keep their appointments. Just somehow they'll say to me, oh, I feel like I feel accountable. I know I'm coming. So I wanted to make sure that I took my medication, or I had data for you. So I think just keeping engaged with your healthcare team is also really important. And then just advocating for yourself, asking about the test. Hopefully your healthcare team is being proactive, but we know that sometimes things get busy and things do slip through the cracks. And so you are your own best advocate, or you can advocate for your family members as well. So, all right. Well, that has been an awesome discussion. It looks like there are a lot of questions coming in from the audience. So I'm going to go ahead and I'm going to start looking at some of those and asking those for our panel. So I'm going to go with this first one here. The question is, are all of these medications like GLP-1s, SGLT2 inhibitors, finerenone, or statins, medications, things that people will need to be on for their entire lives? Or do some people eventually come off of these medications? So that's a really good question. Any panelists eager to answer this one?
I'm happy to jump in. I'm going to give people sort of the good news, bad news situation, right? So when we think about these medicines to keep the heart and kidneys healthy, you want to have that benefit long term. So these are drugs that should be considered, lifetime medications. However, particularly when it comes to use of some of the drugs that are good at lowering glucose, I have found in my personal practice, for example, that if I start someone on a GLP-1 receptor agonist, often I can take away a lot of their other medicines, right? So I'm actually simplifying things and making their diabetes management easier. So it's a really nice trade-off. But you want your heart and your kidneys to be healthy for the rest of your life. There's not going to come a day where that's something that you just decide isn't important any longer. So I would consider these to be therapies to be used indefinitely.
Thanks.
This kind of question comes up quite a lot, and I hear it from my patients, and I totally agree. For better or worse, medicines work when you take them, and they don't work when you don't take them, and so that's just how medicines are, and so you want to get the benefit for as long as you can, um, and it's got to be a medicine that you tolerate. Again, if you're having side effects or problems, we didn't really talk about the different potential side effects of these different medicines. There are some side effects. Every medicine has them. If you're having that, speak to your healthcare professional. And maybe changing to a different medicine is going to be a better choice for you. So don't be afraid to bring that up.
And I would just add that if you want to think about development of cardiovascular disease, in general, what we're talking about is something that's progressive. So these pathophysiological mechanisms, they kind of worsen over time, especially when you have metabolic issues like diabetes, obesity, high blood pressure, and this injury can continue to converge and create these hard cardiovascular problems. So in general, it's harder to, it's a lot of it is about slowing progression rather than solving the problem. But one thing I would say is that to give yourself the best chance is definitely going back to that point about lifestyle, because lifestyle, if you look at all the different risk factors of cardiovascular disease, whether it's obesity, diabetes, high blood pressure, lipidemia, chronic kidney disease, every one of these key pieces of advice is this change in your diet, exercise, which two of the 10 things that Dr. Gabbay mentioned earlier, because they hit every one of those risk factors. And so if you can make dramatic changes, that gives you your best chance of not just slowing, maybe there could be in some people a regression in your risk going forward. So that's one thing I would add.
Thanks. And I just want to encourage our audience also, if you have more questions, please throw them into the chat. We're going to try to answer as many of them as we can. Just continuing on with this question, I agree with everything that the panelists said. I'll just add that I think it just depends what medications a person's taking. As Dr. Green kind of referred to, I've seen plenty of cases in type 2 diabetes where when we add on drugs like GLP-1 agonists and SGLT2 inhibitors, often we're able to remove other drugs like maybe insulin or sulfonylureas. And so sometimes it is trading. It's not just adding to that medication list. All right, let's see what else we have. So we have someone asked that if spilling protein in their urine, does that mean you need to be cautious about ingesting foods that have high protein? Dr. Gabbay, you want to start?
Sure. Yeah. So it's a great question, because you might think that if you ate more protein, more is going to leak through. Generally, you don't need to worry about the protein intake until you have really advanced kidney disease. When the kidney disease is really advanced, you're already seeing a kidney specialist. Then there may be a role in reducing the amount of protein that you have in your diet. But in general, what you're eating is not determining, the protein you eat is not determining how much leaks out.
Thank you. And kind of continuing on, there was also a question that, is there any benefit from limiting excessive protein consumption before kidney disease occurs?
Not really, no.
All right, great. So another question that came up also, this one's about advanced stages of chronic kidney disease. What risk factors are associated with greater increased risk? So kind of, I guess, what else might contribute to worsening CKD?
So I might take that. That's okay.
Yeah.
I actually want to, like, we talked a little bit about this concept of interconnectedness. And there's actually, we've covered a lot, right? So we obviously, a lot of people on this in this audience have got diabetes. And we talked about the different relationships. So, for example, heart failure can lead to kidney disease. Kidney disease can lead to high blood pressure. High blood pressure in itself can lead to cardiovascular disease. There's such an interconnected web. I would actually refer audience to a new initiative from the American Heart Association. There's a presidential advisory talking about this concept of interconnectedness of different systems. And a really interesting thing they've done is to talk about this kind of staging of cardiovascular, kidney, metabolic health. And so if I just lay out broadly these stages, so stage 0 is you're completely healthy, 0 risk factors, and that's where you want to be for as long as possible. Stage 1 is where you've got some excess adiposity or dysfunctional adiposity. So maybe you're overweight, or you have an expanded waistline, or I think that people are varied. So there are people who have normal weight, normal waist size, but are still at risk. They may have a pre-diabetes, for example. So maybe they have adipose tissue in the wrong places, genetically predisposed. If you continue for long enough, you may enter stage 2, which I think is going to answer this question, which is around the risk factors. So stage 2 is when you develop actual metabolic risk factors. So you've got, as you mentioned earlier, you've got diabetes, high blood pressure, obesity, dyslipidemia, chronic kidney disease. These risk factors, when they're present in the same person, as I say, can multiply your risk, and they can take you into the later stages over time. So stage 3 is when you've got something called subclinical atherosclerotic cardiovascular disease. That means maybe if you had an incidental scan or test, it might be picked up, but you just haven't had the symptoms yet. So it could be, as Dr. Green was mentioning, calcium in a coronary CT. It could be an ultrasound, which shows that you've got atherosclerosis of lining your arteries, or it could be something that picked up on an echocardiogram. So you've got maybe some signs of heart failure, you just haven't got the symptoms yet. And then the final stage is when you've got the symptoms. So that's actually quite a nice way of looking at it, because a lot of patients will have very complex history. They're being seen by an endocrinologist or plus a cardiologist, plus a nephrologist, and they're wondering, how did this happen to me? I thought I just had diabetes. It's just that what you've had is a confluence of different risk factors, and they can come together to cause these end organ complications. So I would look at it again. It's all about managing risk. So again, if you do the 10 things that Dr. Gabbay mentioned at the beginning, what you're doing is you're slowing that progression and hopefully even regressing in terms of your risk.
Can I just highlight, like, what if I had to pick one, and it's hard to pick one because there are multiple, but blood pressure. It's super common. Most people with kidney disease, most people with heart disease have high blood pressure, and blood pressure is manageable. We have good treatments. We know how to treat blood pressure. Getting it to less than 130/80 can make a huge difference. So if you take away one thing, yeah, and measure your blood pressure at home. it's worthwhile, because again, what's really common, my patients come in, they say, I had traffic getting here, my blood pressure is high, it's normally fine. Well, check it at home and see if you're below that 130/80 number.
Great points. Yeah. And the fact that if you do need medication for your blood pressure, most of them are generic. So they are very, very affordable. So those are fantastic points. The next question, I think, is for Dr. Green. The person's asking, please remind us, what is the name of that new heart test that determines your heart health now and in the future?
Well, it's kind of a long name. It's N-terminal proBNP, but if you can remember BNP, you can ask your doctor whether or not you need to have that done. So just remember those 3 letters, BNP, and whoever's taking care of you will know what you're talking about.
Thank you. And this next question is interesting. So, a lot of people, fortunately, are using continuous glucose monitors and measuring their glucose. And some people may have more variability, so lots of highs and lots of lows. Does that higher glucose variability impact kidney health?
I can say, go ahead.
Oh, these are difficult questions to answer. When people have looked at the association between glucose variability and complications, there does seem to be an association, but these are not, for example, randomized controlled trials. So it's not the best evidence to suggest that glycemic variability increases the risk of complications, but it might. I think that's the best answer that we can give.
Great. And I'll put in a plug that CGM use definitely will let us know about that glucose variability compared to an A1C, where your A1C could be at your goal. It could be less than 7%, but you could be having a lot of highs and a lot of lows. So, all right. Next question is, this is for Dr. Gabbay. So can you speak a bit about what guidelines there are for people with type 1 diabetes and SGLT2 use? And this person is saying that, for example, their doctor cannot prescribe, nor does insurance cover for type 1 because they're FDA approved for type 2. So yes, can you address that?
Good. It's a good question. This has been around for a while. There have been attempts to get SGLT2 inhibitors approved for people with type 1 diabetes, and essentially where we are now is that they're not approved for the use for glucose control to manage blood glucose. And the reason there's concern about using these medications in people with type 1 diabetes, the risk of diabetic ketoacidosis is much higher with these medications, particularly in people with type 1 diabetes. So there is some danger associated with using them and some concern, and that's why the FDA is not approved it for that purpose. But it is approved, or it's acceptable to use as treatment when somebody has chronic kidney disease. For the treatment of chronic kidney disease, the way medications are approved by the FDA is for a purpose, and known as an indication. So if the indication is for chronic kidney disease, yes, you can use it. And again, beware of the risk of diabetic ketoacidosis. So it can be used, and many of us do use it for its kidney protective effects and its heart failure protective effects.
Great, thank you. Oh, Dr. Green, did you want to add anything?
Yes, I would just wanted to add that this is an area of great interest because there are limited proven options to slow the progression of kidney disease in people with type 1 diabetes. In the future, we are likely to see results of the effects of different classes of medications, such as the non-steroidal MRAs, and maybe in the pipeline, the aldosterone synthase inhibitors, specifically in trials of people with type 1 diabetes, to see if the drugs provide a similar benefit to what's been seen in people with chronic kidney disease and type 2 diabetes, or frankly, chronic kidney disease without diabetes. So that information should be available in the future. And those are medications that should not pose an increased risk of diabetic ketoacidosis. So stay tuned.
Great, thank you. So another audience question, this person, and I don't know if this person has type 1 or type 2 diabetes in this case, but they're saying that their kidney function's healthy, blood pressure is healthy, yet their cardiologist thought it'd be a good idea to put them on an SGLT2 inhibitor. So is there a reason you can think of why, in this case, it might be prescribed for this person?
I can take a stab. I would say this is it's a clinical decision. So I would guess that there's something in the clinical assessment of the patient where if you look at the history, the family history, all the different risk factors has made them think that for some reason they are at increased cardiovascular risk, and that's why SGLT2s are indicated. But honestly, without knowing the details, it's really difficult to make that call.
Yeah, I agree. I mean, if it's for type 2, if the person has type 2 diabetes, it can be used for glucose lowering. And, you know, that alone would be a great reason to use it. Glucose lowering and maybe a moderate, a little bit of weight loss. It's not going to cause weight gain or hypoglycemia. So it can also be a great option just to treat diabetes. All right. Someone is asking if we can clarify what a CT test is and why someone would want to have this done.
Yeah, so I talked about that. So it's the coronary calcium score. And this is not a test that you should walk in and request. I think it's a test that is useful in very particular situations. And the way that I use it most often is if I am seeing someone in my clinic with diabetes who doesn't have a diagnosis of cardiovascular disease, but has a lot of risk factors for cardiovascular disease. And it makes me worry that maybe I need to have, for example, more strict goals for management of their cholesterol. Frankly, this is when I use it most often. If I need to have more strict cholesterol targets for this person than I would otherwise recommend to them. And so if I get the coronary calcium scoring, again, this essentially CT looking for calcium in the arteries that supply the heart muscle. If calcium is there, and in particular, if it is high compared to individuals of similar ages, or if it's present to a moderate or severe degree, it will change my management. And if there's a great deal of calcium in the coronary arteries, again, that is suggestive of atherosclerosis involving those arteries, I will probably have the person see a cardiologist as well. But it's not a test that I order for most of the patients that I see. It's very helpful if I know that positive results or abnormal results would change how I am treating someone.
Great. Thank you for that. Well, there's been so many. Oh, yeah, go ahead.
Well, I just realized something we didn't talk about, which I think is important, and around the change in the goals of cholesterol. What is a good cholesterol or a healthy cholesterol for people with diabetes? And so the recommendations from the American Diabetes Association a couple of years ago changed, and it's the LDL cholesterol, the bad cholesterol. If you have diabetes, you're age 40 to 75, and you have diabetes and multiple risk factors for heart disease, that LDL cholesterol should be 70 or less. And if you have heart disease and diabetes, you've had a heart attack, for example, and diabetes, then the LDL cholesterol should be all the way down to 55. And that's a lot lower than it used to be. But we know that if you can do that, people live longer. And so it's important for people to know those numbers. And, who knows, you may be telling your healthcare professional something they hadn't sort of read about yet.
Awesome. I'm so glad that you brought that up. So, wow, we are getting near to the end, and thank you to the audience for all those great questions. I want to make sure we leave the audience with some really good practical pearls. So I'm going to ask a final question to each of our panelists, starting off with Dr. Surendranathan. What is the most important piece of advice that you'd share with someone who wants to protect their heart and kidney health?
My piece of advice is look out for any tests for that indicate that you have diminished kidney function, so chronic kidney disease. And there's an interesting study which is done on 29 million Americans, which showed that in diabetics, who are some of the highest risk people, only something like 29% of diabetics have both the EGFR and the UACR. It's even lower for hypertensives. It's kind of 40% if you've got both. So these are actually relatively, what I would say, low numbers, considering just how important it is for these patients to be managing cardiovascular risk. And UACR in particular is not done well. It's not done enough. And it can be a real key marker of your cardiovascular risk. So one thing to take away is ask for your urine, your UACR. This could be something that really is a great indicator of your level of risk.
Great, thanks. So yes, get those tests. All right, Dr. Green, what steps can patients take if they want to be more active in their care and decision making?
Well, I was going to say something very similar, so I'll add on to the previous comment. And what I would suggest is, let's take the kidney labs, for example, is if the levels are abnormal, to ask how the levels have been changing over time. What you really like to see, if the levels aren't normal, particularly that urine albumin level, is you want it to stay flat, to not get worse, or even get better. The level can be reduced with a lot of the very effective medicines that we have available now. So ask your provider, what's happening with these levels? Have they gone down after I started that new medicine? Or do I need to start a medicine or start another medicine to get that level down further?
Awesome. Great advice. And then Dr. Gabbay, if someone is feeling scared about complications, what should they know about the progress being made in diabetes care?
It's incredible. I've been in this field for many years, and we have more tools now to prevent complications from advancing than we've ever had before. And so, as my colleague said, get screened to know whether you have it, and know that there's a lot that can be done to prevent it from being a problem for you.
Great. Well, I'd like to thank the panel so much for your time. I want to thank the audience for attending this, and I hope that everyone in the audience feels more informed and empowered to take control of your health and live well with diabetes. Thank you so much. Have a wonderful night, everyone.
Thank you.